you so much for attending today's webinar here with MDA. We are going to talk about care transitions, and I am excited to introduce our three presenters today. First, we have Christina Trout. Secondly, we have Areti Vasilopoulos. And finally, we have Dr. Vera Pandian. And I will hand it off to Christina to begin the webinar.
Hi, everyone. I am glad to be presenting on the topic of transitions, and the learning objectives are listed here, including identifying the challenges to navigating the pediatric healthcare transition to adult healthcare, identify care center specific solutions and transition challenges, and evaluate opportunities to adjust current procedures to include best practices. And it says exemplary institutions, but I think we've had our own conversations about the need to improve in areas for every center. So again, this is kind of the key agenda questions. We're going to talk about transition, the challenges, what centers are doing. We'll go through some tools and guidance, and then some topics that are probably more unique to neuromuscular disorders. And then what all of our roles are. As you can tell by the panel, I'm a nurse, we have a psychology representative and our healthcare provider, but we have many other team members who also play a role, and what things that we can do to help bridge the gap between the pediatrics and adult healthcare systems. Next slide. And you can go to the next slide. We're going to talk about what is transition. Transition is a particularly difficult topic for our neuromuscular patients because these are disorders that tend to be complex. Many of them have an evolving medical course over time, and these patients also experience this dichotomy where they're becoming more physically dependent on their caregivers, but they still have those same desires to remain autonomous and seek independence and pursue adult lifestyles. With the impact of newer therapies, we're also seeing a wider range of physical abilities, both within our historical patient populations like Duchenne and SMA, but we're also seeing a new population, those that are identified through newborn screening, including SMA, Pompe, and maybe even Duchenne in the future, where we may have a new population that are waiting for their symptoms to appear. And they're actually, starting therapies before there are symptoms, and that may look very difficult or different for them to recognize the severity or the impact of their disease over time. I think other adolescent transition planning concepts apply to those patient populations because it's very common in adolescence to feel invincible and be ready for adulthood and kind of not embrace your healthcare needs and continue them into their adult years. So we will need to assess needs individually and treat the individual and their family and their needs as they present, and then continue to monitor them even if their symptoms are not manifesting. In addition to that, for our typical populations where there is physical disability and sometimes neurocognitive or neuropsych challenges as well, this is not simply addressing their health care, but how they intersect with their caregiving needs, their activities of daily living, their education, their ability to find employment, and of course, adult lifestyles. Next slide. So healthcare transition planning is not a single event. Many people equate it with a transfer of care, and this is not the case. There is more to this, and it involves a lot of different healthcare providers as well as other teams. The goal is, of course, to prevent negative outcomes and maximize those positive outcomes, improving the ability of the youth or young adults to manage their own health care and use healthcare systems effectively, as well as to ensure an organized clinical process in pediatric and adult practices to facilitate the transfer of care, but also making sure that the individuals are integrated into that healthcare system. Next slide. And when we think about transition, we know that this is part of normal, healthy development. We all go through this process. It occurs across the lifespan. It's not like all of a sudden our growth is, stopped and here we are, we're not moving forward. And we know for our patients, this can be made a lot easier when there's a cohesive approach to communication and that the care is coordinated. Again, this is patient-centered and individualized to the needs of the teen and their family because teens, their families will all be different from each other as well. Next slide. When we take a look at historically, how have we done in healthcare with our neuromuscular patient populations? We can look to the literature to see what evidence there is of successful transition planning and transition as a whole. And we have some old data. MD-StarNet is a database, for those that don't know. It's the Muscular Dystrophy Surveillance Tracking and Research Network. That is where medical records are abstracted from several different states in the US. And they document whether or not activities are present or not present. And historically, they were looking at things like, was an echocardiogram done or PFTs? But there was an additional study looking at documentation specific to the transition process, what documentation looked like to say that those conversations are happening. And as you can see in MD-StarNet and in some of the others in the UK as well, many times the documentation doesn't exist. So you have to wonder, did the conversation take place as well? And then we know by looking at our patients in clinic that many of them are not able to move outside of the family home. Many of them find challenges in entering educational practices beyond high school, and of course entering the workforce. Again, looking kind of at the UK, so this is not just unique to the United States, but less than half go on to college. This particular study found that only 13% had employment, and there was very few people that were actively living adult lifestyles for those that had Duchenne muscular dystrophy in particular. Next slide. There is a great resource to talk all things transition, and that's Got Transition, and I've listed the website there. And this is really guidance not just for the families, but really for pediatric practices about how to integrate transition planning into your practice, whether that is in primary care or in a specialty care. And they recommend that your hospital or your clinic have a policy that tells the youth and the family about any transition policy that you do have beginning around age 12. So this is so that they can plan, will my care continue with this group forever? Or will there be a time when we're expected to have a different group of providers helping us? And then it's around age 14 where you actually initiate healthcare transition planning, and then through age 16, assessing not just readiness, but are they adopting these healthcare behaviors that suggest they're becoming ready for the adult healthcare experience. And then by 18, that's kind of the age that we typically think of individuals becoming adults. We should start actually integrating them into either an adult practice, or our practice needs to evolve and treat them like they are adults. And then we're given some grace period there between the ages of up to 26, where we continue to work on making sure that they're integrated into an adult healthcare environment. Next slide.
Can I ask a quick question?
Yeah.
So I think this is great in terms of the recommended transition timeline, right? You brought up the good point. When we talk about transition, it's not just a medical care transition; it's actually transitioning into their adolescent and social milestones, and so I'm curious about I know there are recommendations and guidelines in terms of starting to talk around age 12. What's your practice per se in the clinics, and do you directly translate this into the clinic, and what challenges that we may face when some of us think that age 12 is too soon to start talking about transition.
Right.
I'm curious to hear your thoughts.
Yeah, it really is too young to be talking about adult healthcare at age 12. But there are many freestanding children's hospitals where the families are blindsided at age 18 to 21 when they learn that if their child is admitted to a hospital, it won't be in that hospital, and it would be one across town where nobody knows them. Similarly, they haven't practiced or learned any of the skills to kind of advocate on their own, and families tend to be a little protected in pediatrics. So absolutely not. This is not to think that the youth should start behaving like an adult all in the sudden. It's to provide anticipatory guidance about what this is going to look like as they move through this. And some of my own challenges at my own institution, we went through changes in leadership, for example. And we really felt like as an entire organization in pediatrics, we could benefit from having policy that helped all of our subspecialties. We have specialty nurse meetings, for example, and we realized all of the nurses were developing materials for transition planning for our own certifications, whether that be MDA, PPMD, and then of course the congenital heart cystic fibrosis. So we're all going through the same materials and some of these patients are followed in multiple subspecialties. So we really could have benefited from an organizational standpoint to have all these materials and documentation in a way that we could share across within our own organization, and then with Care Everywhere, that would actually share to other organizations as well.
Yeah, I think, I don't know if already, if any, your experience.
Yeah. So what I was going to say was when here in my institution, and the way I approach this with families is less kind of, this is happening now, but more, can we talk about how involved you are in your care? What does this look like? How can we help get you more involved as an early adolescent continued on? And so I sometimes use the term transition, but a lot of times I just highlight that it's mostly for us to understand your involvement and support it. So it's not a blindsided event, right?
Yeah, I agree. I think I use this as an opportunity just to kind of talk to the patients in person, alone, without the families, and try to get them up to speed in terms of even try to kind of train them to make decisions for their treatment, for their care. With especially in Duchenne right now with the gene therapy and stuff, a lot of times when we talk to the families and versus talking to the individual patient, we're learning a lot more new things. Like the patient may not be able to want to get treated or anything like that, whereas the families would say push for it. I think it's very important that I've learned to start talking to these patients individually, at least starting that as a practice at age 12 has been helpful.
Absolutely.
I also think it gives you an opportunity to find out what their goals are. And then, because we're in healthcare, we talk a lot about the goals of healthcare, but we really can help them to determine if they're on track in a lot of different ways to meet those goals. Like if their goal is to, become a writer or work in sports, we need to be thinking about, what do they need to make that happen? And that's true of all children, right? I mean, all children going into adolescence and adult life really benefit from guidance to make sure that they know where they're going. And we all don't know where we're going, in adolescence and young adult life. And we have the grace to be able to change our direction.
It helps us for them to open up and talk more about things that they typically don't talk about, like their, once into their adolescence, their sexuality, if they're using other drugs, all of those things. I think it has really been helpful when you start these conversations early on.
And to model that for parents, right? To model for parents what this can be, this shift to help parents along as well, and kind of seeing them that way and providing that space for them. So I think us leading that makes it feel better and a bit more comfortable sometimes too. As this is just the policy, this is how our clinic goes, very nonchalant about it, I think is worthwhile.
Awesome. So thanks, Christina.
Yeah. What's our next slide? This is kind of more on what we were just talking, that Gut Transition does have a lot of tools for organizations who are wanting to make this their approach. They have lots of different tools that can be given to families. There are, for trainees that are coming through your program, I found the videos to be fun. Like people ask about the transition readiness tools, and they're like, how would I actually use that in a clinic setting? And so some of these videos actually show you the right way to use them and the wrong way, and how you would, again, what does it look like when you're talking to these families? It doesn't necessarily have to be as awkward as it sometimes sounds, like talking to a 12-year-old or a 14-year-old. What's our next slide? So this is another one worth talking about as well. We talk a lot about the differences between pediatric and adult healthcare culture. And again, I've mentioned several times family-centered. In pediatrics, we tend to have, when we talk about multidisciplinary care, we actually have a really big team. We've had years to develop these teams. We're working closely together. And I would argue that in pediatrics, we have more support from social work, nursing, care coordinators, even pharmacy, psychology. And I feel like probably the adult providers, of which we don't even have them on our panel, it would have been great to have an adult provider here. Talk a little bit about their experience. And just recently, even at the national MDA meeting, one of the adult providers made some really valid and concrete comments about, they're expected to see patients probably in a quicker fashion. The turnover of their clinic rooms happen more quickly. In pediatrics, we tend to say, well, these are pediatric onset disorders, so the adults don't know them, but are we also not giving them the chance because we're hanging on to them in pediatrics when these are people that are very smart and could learn pediatric disorders? And it's possible that we're hanging on to them in our pediatrics and we're not learning the adult topics that our patients are missing out on. So I'd be curious to hear how things go, what you think the cultural differences are between our clinics, peds and adults.
Yeah, I can start. I know I saw a question in the chat. We are going to talk about that topic in the next few slides, so hang on to that question. So I think I completely agree with these differences, right? I think one thing that I also would say is above all of the challenges, I think there's a whole healthcare system itself is a challenge between the pediatric and the adult. Being like you said, one of them is number of patients that they have to see, the responsibilities, even getting paid for some of the assessments that's being happening in the adult clinic. For example, physical therapy assessments, right? If you have a physical therapy as part of your multidisciplinary care in the adult side, you don't get paid for that if you're getting a therapy in the community as your regular therapy schedule. So there's a lot of that comes into play. There are different models that people have been using for transition for healthcare, which we'll talk about that. But I agree. I think there's a lot of support in the pediatric healthcare system per se for this compared to adult. I also becoming more in our practice, we tend to say, hey, we'll just follow you as long as we'll get exemption from, I'm in a standalone pediatric hospital, but we'll get an exception and we'll continue to follow. But I don't think that's a good idea at all. We need to be able to pass them on to the appropriate adult providers. And it's our responsibility also to someone, if we have adult providers who's interested, but we want to keep them up to the speed, it's our responsibility to update them, educate them and get them onto speed. And the other challenge that you would see is if they, if you see them in the clinic, for example, you can see a 22-year, 23-year-old patient in our clinics, but if they get sick, if the emergency room and ICUs have different policies that they won't admit you, then it's just a chaos, right? It's not a good continuity of care.
Yeah, all of those are such good points. Christina, I love the kind of reflection of, are we keeping them and not allowing the opportunity, right, for our adult counterparts to feel more comfortable? And I think that that's really a really thoughtful consideration. But I also agree there's a systemic piece. So what you're describing, we have an imperfect, and we'll talk about the transition plan in my institution, but that kind of challenge with an acute care and what that looks like and how hard it then ultimately leaves the family and the parents and everyone involved feeling, because this is a scary moment. They're receiving, right, acute emergency care and their team can't even be there and they're not even being seen by those they know well. So kind of another systemic piece that we can try to advocate and work on, but really we need to also problem solve in real time.
Let's keep our slides moving because I think we circle back to this when we talk about our own clinics as well. So we're all alluding to the importance of transition planning and what happens when it's not there. And I think we're probably most familiar with the barriers and the problems than we are the solutions. So without transition planning, there can be a loss of continuity or a complete loss of care. People stop coming to their clinics if they feel like they're not served in pediatrics. There can also be an actual loss of information, like people lose their genetic testing information. If they stop they were seen in pediatrics, they either move or they're up to the adult clinics. Some of that historical information can actually be lost. This is not just in the specialty care, but in primary care. So part of our clinic duties is to make sure that we have the appropriate providers in their primary care setting as well. We've talked a lot about the patients not being prepared for the adult healthcare style. There are, in the general adolescent medicine literature, they talk about, patients running out of medications, not recognizing the importance of their appointments and how that can reflect on even a prior authorization. That if you haven't been to clinic, you're not going to get a new documentation for your high-cost medication. So then we started to talk about what does this look like in the emergency situation, that if they're not getting your primary care where there's preventative strategies, you may up in the emergency room. And that can be an unfortunate use of healthcare resources as a place for refills and re-entering the system that you needed for your specialty care. And then on the family side, they can feel like there's maybe a loss of trust as well in the system because they feel it's failed them in some way. Next slide. Next slide. So this was a kind of a figure that was out of the Duchenne Muscular Dystrophy Care Considerations having to do with transition planning. But I think a lot of our neuromuscular patients really have this same level of complexity. That when we talk about transition planning, we're not just talking about healthcare, but how that intersects with getting their activities of daily living completed. And then, of course, how they get about not just in their home, but in their community, their school, their jobs eventually. The need for accessible transportation, accessible housing, and then how they interact with others, that this can be a barrier for their socialization. It can be a barrier for them having and maintaining relationships that are meaningful and develop into, marriage and intimacy as well. So we can talk about some of these, I think, in the future slides here. Let's go forward. We have already been discussing some of the barriers to healthcare transition. So we may have already covered these. We can kind of look through here. I kind of labeled them from the youth and the family perspective, being fearful of the adult experience. They have a bond with their pediatric providers. Let's see if we missed on any topics that we should be covering here. Talked a little bit about the system difficulties. Perhaps we should touch a little bit more on that. You talked about your freestanding hospital. We have a freestanding hospital, but it's closely affiliated in our university setting to our adult system. So we have a unique situation that we can actually reach out to our adult counterparts. And as we transition, we can actually have them seen in pediatrics in our clinic in neuromuscular, and one by one, we can actually transition them into the adult clinics so that it's not happening all at once, that they are slowly beginning to have that familiarity with adult healthcare practices, but still maintaining the support of the team that knows them best. And then do you guys want to talk a little bit about some of the barriers that you're having in your own practices?
Sure. I mean, I think there are questions that I'm going to try to answer those questions and answer the barriers. One of the things that came up with Dr. Drew Thorson was, we talk about the adult providers don't get paid, but how are the one of the challenge that he rightly brings up is the pediatric providers don't get time to do this full transition or educate the adult providers. I think that's a valid point. We, in this whole RVU based environment of how many patients you're seeing, how much RVUs you make, I think it's that's a barrier, and I think you have to. There are several ways that you can work through that. One of the things that I have done is again, talking to our administration and make sure that we get some protected time to do these multidisciplinary clinics, explaining that these are complex. And I have used also MDA Care Center grant funding, depending on the availability, to sort of pivot those fundings towards the time. We can, if we move on, they're going to talk about how each center is handling the transition. So I can get to that in terms of other challenges. Obviously, getting ours is a standalone hospital. We have an affiliation with the university hospital, but we are not connected. So there's separate facilities. So challenge is also if I want to bring them into our clinic, for example, like depending on the age of the patient, it's not happening. It's a challenge to bring adult providers into the clinic. Now, we also have a policy that when they completely transition into adult state, we want to see them back at least one time to make sure that they're completely plugged in. And we have had some challenges bringing them back also. I think there's a lot of barriers, and we can keep listing.
Yeah. Should we go on to the next?
Yeah.
So this is just trying to think about some of the topics. When we worked on the care considerations for Duchenne muscular dystrophy, the adult providers reached out to us and talked about the conversations that were not being had prior to them coming to the adult clinic, or that they were in the middle of those conversations and that the timing was difficult for the patient or their family. And some of those are the physical health, facing body image changes, loss of ambulation right at this critical time of changing providers. Of course, then pain and discomfort, which I feel like usually gets dealt with pretty well. I think that's one of the areas that we do well most of the time. And then reproductive health needs. And this is where, again, that the adult providers are probably, this is something that would regularly be discussed in their clinics. So in our clinic, for example, we view the time of adolescence as a time to review genetic counseling, make sure that they are connected with their primary care for birth control, but also talking about the ability to actually have intimacy and father or be a mother of a child, and any medications that they might be on. So this is, again, one of those missed conversations sometimes when we're focused on some of the other issues. And then mental health, of course, is always of concern, but I think it's particularly true as people come out of high school, where there's this naturally built-in social network where they're seeing their friends day in and day out if they're having activities. But leaving and moving off to college can be a difficult transition for all youth, or if they're not going to college, that next step can mean that they've had to reestablish all new social structure, which can bring about anxiety for them as well as their parents. We have many parents that are not prepared for this. And so if they have a lot of caregiving needs, there needs to be a discussion about who will be with the individual that has the neuromuscular condition if they're either staying at home or going to work. And then I think we're going to talk about urgent care at the end. So maybe we'll move to that. I see that there's another question in there. Do you want to address that one there? It
was a comment which we'll get also. I think, when you have a multidisciplinary team, I completely agree. Sometimes each team has their own transition plan, which I have had the same challenges. Our pulmonary team has their own transition plan. Our cardiology team has their own transition plan. I completely agree. That is a huge challenge. And I can talk from my experience. What we had come up with in our institution is for the neuromuscular kids, we're going to try to merge all of them into one, and we're going to follow our muscular dystrophy transition guidelines, which they have been agreeable so far. I completely get that point.
Yeah, I like that you also say we all have the same challenges. That in some way kind of feels really validating and still quite sad, because it's very similar here. And it was kind of some transitioning at different steps. So it's not perfect, and I can't say we're consistent, but I think we're trying to do the same thing that you're describing of having, at least for ours, and we're toying with the idea of maybe it being even more specialized, where it depends on the neuromuscular diagnosis itself, but it's really challenging.
Let's move on to our next slide. These are conversations that I think are also going to be discussed as we go on, but some of the specific competencies that our emerging adults might have. There's a push to have alone time for age-appropriate conversations, and I think most of our clinics have known that this has been a real challenge that they're seeing, 4 or 5 different subspecialties that day, and doing lots of tests. And when is it that each individual is going to have alone time with the team for these more private conversations? I think it's really important, and we'll continue to discuss that there will be some that need actual formal testing or repeat formal testing to determine their competency to take on their own healthcare practices as adults. And others that just need another level of support. And I think this is also a time that it's misunderstood that we're trying to say that youth are expected to become completely independent and that their parents will no longer be a part of their lives and help them. That would be really unrealistic. I think anyone facing changes in healthcare benefits from the support of either their spouse, a close family friend. So the intention is not to take youth away from their support systems, but to make sure that we have supports in place and know who's able to make decisions independently and who's just having people there for support. So making sure that the youth understand or have a deeper understanding of their healthcare recommendations is important. And then the big one that I think our clinic struggles with is making sure that they understand their healthcare benefits, whether that be Medicaid waivers, and the ability to go out and have a gainful employment, have income without losing the healthcare benefits that are so important. So in these situations, we enlist a social worker, but even we find that things such as special needs trust and ABLE accounts are outside the scope of what we can provide in a clinic. And I think it can be helpful, though, to families to know what those resources look like, so that you could maybe refer them to legal guidance, whatever that is in your area. So let's go to the next slide. And along those, I think we're going to also come back to this, but one of the concerns adult providers have is whether or not we've had honest conversations as we've added and escalated care and therapies throughout these teen years. Have we had good conversations about the goals of those interventions and what their goals are for their future? And are we all on track for those things? If there is an advanced directive where they feel like they know the ceiling for what their care should look like, is that documented, and is it documented before a crisis occurs? And I also would say, in defense of sometimes not having those documents, is that during this time, many of the youth have never actually faced a critical crisis in their health care. And I think it's hard to know what you would consider doing or not doing when you've never experienced illness. I think most of us say, well, if you found me in a car accident without and I'm not breathing or I don't have a pulse, you may say, I don't want to be kept alive in a persistent vegetative state. Everybody says that. I don't know anybody that says, yeah, keep me alive at all costs. But in our patient population, I don't think that's most of the time what they're facing. It's this very slow escalation in their care needs. And sometimes there's surgical interventions and whatnot that change their perception of what they would do or not do. So that's always a fluid topic, I think.
Just to add to that one, I think in our experience, I'm sure you all have that same involving palliative care sort of early on has always been helpful in terms of having these discussions ongoing and documentation and stuff, rather than bringing them on at the last minute when actually someone is in the hospital trying to, going through all of this at the last moment. It has been helpful in terms of building relationships with the families and people get scared when they hear the term palliative care, but I think discussing that from the somewhat early on and having them involved in the clinic has been helpful.
We can go to the next slide. And the next.
I think this is probably just all going to talk about how we are handling transition part. I don't know if I already want to start and then.
I kind of already mentioned ours, that we have identified adult providers who are interested in our patient population. And so we reached out to them. We said, hey, you saw one of our patients, the family reported back to us. They really enjoyed their visit with you. And then we developed that relationship from our side with the adult providers. That's been very helpful. And you know, honestly, we're not seeing them day to day in the hallways. Our hospital is big enough that we don't, but we feel like we've bridged that gap so that we have communication. They typically notify us if our patient is in the adult hospital. And we've also reached out to the inpatient units. We have nurse practitioners that are hospitalists in our pulmonary care unit. So we have again, you know, done person-to-person in-servicing kind of to make sure we're all on the same page. We've also had a number of individuals that, due to their disability, can no longer travel long distances for their care. Telehealth works when we're still within the state boundary. We have also identified kind of people in larger communities, cardiologists, pulmonologists that do a nice job. And we have asked, will you be willing to take on referrals? And so we've actually had nice relationships between our organization and theirs, just by reaching out and making sure that we see that they know that we appreciate the care that they're delivering and that we're wanting to learn from each other as well.
Yeah. So at our institution, we had identified that this wasn't being done consistently, that we kind of had different plans for different patients, and that probably that wasn't appropriate, right? It wasn't equal care. So we had a retreat that was kind of broken up into different stages that involved the pediatrics team, some hospital administration, some adult team members that were interested. So we had an adult pulmonologist and our adult neuromuscular provider as well. And we also had, and I'll talk about this later on, but we had some patients representatives as well. So kind of patients themselves, parents, things like that. And we really chatted a lot in advance of it, but also in that day kind of long retreat about what could be done, what could we adjust, what might this look like. And so we did develop ultimately a protocol, and it is quite imperfect because there are not counterparts of all of us on the adult side. So the adult neuromuscular clinic does not have a psychologist, does not have PT and OT, things like that. And so some of those pieces remain, and that's a challenge from a capacity standpoint for sure, but it ends up being quite formal. So we start having administering transition readiness assessments, which we'll talk about and kind of highlight a little bit later as well, and start the discussion and reevaluate at each visit. And then we always have rounds at the start of our neuromuscular clinic. And so we kind of discuss, if we get to one that's at that age, we'll chat about where they are on that process. And similar to you, Dr. Pandis, that we have this kind of one visit follow-up even after. So we'll see them, we'll transition, they'll see adult, and then we'll see us again, and we'll be able to get feedback from them. And I think that's been really helpful to hear, both for the families to feel like there's that continuity, but also for us. I mean, we care about them and we've seen them for so many years that I think we also get nervous, like, what is it looking like? And we have really great adult providers. And so getting to hear that feedback and supporting the families has been nice as well.
Yeah, audience, whoever is listening, if you guys have any cool ideas that you're doing in your hospital, feel free to chime in or put in the chat. We all want to learn. We can do similar to Iowa, I think. Also, we have identified we have made our specialists in charge of identifying their own peer and the adult side. So our pulmonologists identified a pulmonologist on the adult side, cardiology group did that, and we have our nurse coordinator who works obviously magics in terms of transition, but we also have a transition nurse coordinator for whole neurology section. Does all of the transition planning. It's sort of a formal process, protocol process, but we have as you all know now, transitioning is you get a point if you have a formal transition process in the U.S. World Health and News reporting system. So hospitals are also paying attention to that. So with that, we are having actually a transition coordinator for neurology 1 or 2, and they kind of help us in transitioning. Most of our patients are local patients. I transition to our adult counterparts, which is across the street. But if they're from out of state, if they have another setup locally that they can go to, or near local center that they can go to, we work that also. And our transition coordinator, if they're out of state, they make sure that they contact with patients for at least 2 visits to make sure they've actually transitioned all of their care. So that has been helpful. I do know some of the other models. Some places actually have a whole transition clinic as part of the children's. For example, CHOP and again, even some of the Mercy Children's, they have transition clinic where it's part of the whole hospital system, not just for neuromuscular, for any patients. And there are also other models where you can actually bring in an adolescent medicine provider into the clinic and kind of talk about some of these social milestones and things like that.
I think it can also be helpful as one of the coordinator nurses for our neuromuscular program. I'm often reaching out to the school to find out what transition practices are happening at school. I find that the school physical therapist, occupational therapists, teachers, special education are really connecting them with vocational rehabilitation and services in the community, as well as our efforts. And so the combination just needs to be brought together. Having a coordinator to kind of pull those things together and know who's doing what can be really helpful.
We had a question in there. So what do you do if a patient sees an adult provider and voices they don't want to transition during their follow-up visit with you? What a great question. And one that I'm grateful hasn't explicitly come up. We usually kind of broach it, and of course everyone else chime in, but we usually broach it of kind of what went well, what were the challenges, and much more from a problem solving and less from a you don't have to do it if you don't like it standpoint. It's more of a this is happening and how can we help it feel best. So we haven't had anyone, they've voiced challenges and we problem solved them, but we never had someone that outright was like, this is awful. And I think that's also a reflection of, I think the counterparts were identified and these are really thoughtful, lovely providers that really cared. And I think the patients get to really see that. So I think we're really fortunate to not have had to a black and white response like that.
Yeah, we've had very little problem with that. We've recently had some transition where Dr. Matthews is no longer going to our outreach locations, which are, 2 and 3 hours away. So those patients are slowly getting used to seeing a different provider. But again, it helps to have the rest of the team still on board. So doing things in a gradual way so that they have the, chance to get used to changes. Change is hard for all of us. So agreed. If you've identified people that are going to do a nice job in general, most of the time it can be smooth in that transition.
One other thing that I can, in our experience that helped is our rehab provider who's in our pediatric rehab clinic is also in the adult neuromuscular clinic. So that has been a huge help for us. So there is at least a continuity of there.
I think families, that is one of the key concepts that families, when I'm talking with them, is they really want that continuity, someone that knows them well and knows the disease well and, can kind of anticipate that. Because, definitely the feedback we hear from families is that when they have to see someone new that doesn't know anything about the disease and doesn't know anything about them, I think that's where they feel most uncomfortable.
Yeah.
I think we can move on to the next slide. All right, Christina, it's you.
Okay, next slide. There's a lot of different resources to guide successful transition. Definitely on the Got Transition website, you can find them. Why don't we just go to the next slide? Because I think it's the Duchenne. So this was the Duchenne Muscular Dystrophy Transition Toolkit in Got Transition, and I think Aridy's going to present a little bit more about transition readiness. But there are historically 3 tools that are available for transition planning. One is a readiness assessment, another is more like a checklist to see if you're making progress in the areas, and then a medical summary. So if you haven't seen that yet, it is referenced at the bottom, and this is specific to Duchenne muscular dystrophy, but there's a lot of elements in this tool that could be used in working with other populations. Next slide. In addition to that, the MDA has really nice youth and young adult materials. I know that some of the websites are under renovation, but there's ready-to-print educational materials, including a transition guidebook. It opens conversations for families, so just simply providing that link in your after-visit summary or sending it through my chart so that they can read more about it. Opens those conversations, that gives them something to think about in between your visits. And then when they come back to you, they may have more questions. So I would encourage you to take a look at those. Next page. And next. So transition teamwork is all about the team. All of your team members are going to be having conversations about their specialty care. And when we think about especially Duchenne and SMA, congenital muscular dystrophy or myotonic dystrophy, often we're thinking about 6 to 10 providers involved in the healthcare by the teen years. In addition, these families will have teachers and guidance counselors and therapists in their community as well. But it really needs to be someone from the healthcare team that's designated to lead and open these discussions. From our team, that tends to be me. That around age 12, I talk about our policy, and by age 14, we're opening the readiness assessment tools and thinking about what is the priorities, what areas are needing the most information. And then, we as providers know these conditions and how they're likely to progress, what happens in other families. So it's our role to provide that anticipatory guidance about what needs they're going to have and how to get those in place before you need them. I really find this important from the social work side of things. As it turns out, Medicaid waivers state to state have long waiting periods. So those resources need to be applied for well in advance of when they're needed. It's also important to document progress so that all the different members of the team, as well as people outside your team, can know what conversations have happened and how those are going. And of course, the young people really need to be celebrated. They're making good progress. They've taken steps. And it's important to celebrate that. If a parent steps out of the room and says, I'm going to let them, have a conversation alone, or they've been asking these questions, acknowledge, wow, that's a big step. I'm really proud of you, and we'll keep moving forward. Next slide. This is a really busy slide, but it's just kind of getting into this role. Who does what on your team? And we can talk a little bit more about that. In our clinic, a lot of the psychosocial needs are a combination of me as a nurse, the social worker, and then we do have a psychologist, but it's really more of a consultation with our psychologist, and then we do a lot of setting people up with community psychologists if they need ongoing counseling or specific services. As the care coordinator, I do a lot of the nuts and bolts of the operation, making sure consents are signed to exchange information, making sure records are transferred place to place, making sure that they have done their paperwork and kept it in order. And then there's a long list here, which we won't go into, but again, it kind of comes back to thinking about what the family's needs are in advance of when they need them and whose roles are some of these. So I'll let both of you kind of talk about what roles people play at your places.
Yeah, I can start. I know go back to one of the first questions, like whose job is it to start the transition? I think, most of the duties that you listed are kind of similar across, but I do think that I think we have to have one person who consistently does this, or maybe two, maybe as a backup. Otherwise, it's a chaos, and the families are not getting the consistent information from the different providers and different visits. So we have identified our nurse coordinator, and our social worker would do this along with our transition care coordinator. So those are the three people we'll talk about on the transition per se at every single visit, and also they get the information from the healthcare providers, multiple specialists in terms of pulmonary plan, cardiology plan. So our cardiologist may mention about the transition, but the whole conversation is done by these group of people, like the social worker, the coordinators. I think that consistency has been a game changer for us.
Yeah, we end up having it so we kind of all decide and talk in rounds and what this is going to look like so that no one is blindsided and kind of goes in after someone else and is surprised. So everyone will mention it and mention the specifics of their plan. So neurology will say what their plan is and that they're planning to move, who they're going to see, pulmonary, so on and so forth. And then social worker make sure any other kind of, there was actually a question in the chat about kind of the insurance consequences in those pieces. So we each kind of, and then from a psychology perspective, I have the conversation with them in completing a transition readiness questionnaire of areas that we can improve, motivational interviewing of how to get some buy-in to support them being interested in this, processing any sort of challenges, talking again about if there's any sort of neurocognitive considerations here that would play a role in what this looks like based on the reports that we have and the evaluations they have completed. So I think what's really wonderful and I appreciate about our team is it's kind of like we all talk about it often, but then delegate the specific components of it that are most appropriate. And then our social worker follows up often with any sort of kind of challenges that have come up and if there are concerns. As well as our nurse coordinator. So the two of them end up having a lot more contact outside of clinic as well. But it's really nice when they hear it similarly from everyone so that it doesn't feel like one person is making the decision that they transition, and rather it's a team effort that we all feel good about and feel aligned with.
One other thing that it's very critical is the documentation, like Christina was saying. A lot of us lack in that. I mean, we did a quick project recently. We all talk about it. Let's go back and look at the charts. How many of us actually documented? So that is not good. I think that is very important. I just want to say it out there. And if people have any templates that they use for transition documentation, feel free to share with the rest of us, and that would be helpful.
I agree. I've been doing this for many years and I still feel like we have these very long conversations, but it's very difficult to make meaningful documentation out of it. I think there's a lot of follow-up that, like you say, between the social work and nursing coordinators, there's a lot of follow-up work that goes in between our visits that tend to be every 6 months, to make sure that people have followed through on their paperwork, turned in their Medicaid papers, that they understand that they have to apply for certain programs. These are busy, we all have busy lives, but these families' lives I think are particularly challenging. And understanding the benefits to the depth that they need to understand them is really beyond what most people have ever had to think about their insurance.
Absolutely.
Lysis, we built our transition documentation for general neurology into Epic. I love that idea. Again, the specialty nurses had worked in our organization trying to get this built into Epic, have one transition document that everybody can add to. And we still think that that would be valuable.
Yeah.
I see here with hyperlinks and transition booklet with various topics to cover, not specific to MDA patients, but we're utilizing it. Yeah. Be great to share those. And next slide. The next series of slides, I don't know that we need to, how are we doing on time here, organizers? Each of these are kind of broken out into those 6 areas for healthcare, activities of daily living, and different activities that really need that extra attention as they're going through transition. So like this one here is talking about that you need somebody on your team to make sure that they're learning self-advocacy skills, gaining access to records, all of these. But I think we should move through these slides because I want Artie to be able to present some of the findings from her specific survey in this area. So why don't we go through these, and then the viewers will have access to these slides and kind of can go through and make sure you're seeing all of them. So why don't we just go through them? If I see something as you're going through each of these slides, I'll mention it, but let's advance the slide. Yeah, you can keep advancing because we've talked a little bit about some of these. And you can keep advancing in the healthcare system or in the educational system. They're, like I said, also addressing these. When we talk about roles, as we look at housing, transportation, clearly through these adolescent roles for those with advancing physical changes, the role of your physical therapist, your OTs, your ATs are really going to be increasing to make sure that they have accessible home environments and that they can get around in their community. So clearly those conversations are critical. Go another slide, let's see where we are. I had already talked about after, high school, it's important to stay connected. MDA has mentorship programs as well, but we can certainly reach out and try to make peer-to-peer advice. We just hosted a small Duchenne conference, and that peer-to-peer contact is so important for families to be able to mentor each other. Let's see. Why don't we go to the next one? Artie, are you up shortly after these? I think you are.
Getting there. I think it's
Okay.
right after this one.
Okay, go one more. There we are. Thank you.
So I want to talk a little bit about kind of how patients feel about their experience. So in that retreat that I mentioned, we had a variety of providers and hospital staff and key stakeholders. And of course, one of the group is family and patients and their experience. And so we had parents of young adults with neuromuscular conditions. It ended up, I think, being mostly Duchenne muscular dystrophy. We had a young adult with Duchenne. And then we had, the parents were different in a few different ways. We had one that had transitioned in a bit of a bumpy way before we put in a protocol. We had one whose son had passed, to kind of really get an understanding of what this felt like in difficult situations. And we were a bit surprised, I think, as providers. And I think, again, this is a moment of self-reflection of checking in on, we think we know what they'll want, but perhaps we might be a little bit off. So there's some quotes here. We kind of looked at this qualitatively after the retreat. We had kind of separate recording and so forth. And so we got this broken down into some themes and what we ended up seeing. And so we have the themes on the left and then some kind of impactful quotes. And what we heard them say was things like they want to be an adult and work with adult providers, that they want to be treated in that way. And even though everyone in the team treats them that way, but when they are in the waiting room, there's toys and cartoons, and there's a misalignment between their right kind of identity and age and what they are surrounded with. They spoke about the benefits potentially of being in adult care and having more resources of being an adult living with Duchenne, employment considerations, opportunities in their community. They thought that maybe there's a quote about treatment, so that their child had a lot of kind of GI challenges, and when they switched to adult GI, they had some other opportunities, options, and kind of considerations for treatments that their pediatric provider wasn't as familiar with. And so I think that was kind of a resilient thought of we think about the logistics and the health and the visits, and that's incredibly important. But people and their identity is also important. And so hearing how resilient they were ready to be is quite nice. And then they talked a little bit, of course, about some of the things that we've been talking about here, which is that they really enjoyed a one-stop shop, right? So the multidisciplinary theme came up of, it's really nice that they came and saw everyone in a morning. And they felt a little bit concerned and uncertain about going to 5 different locations for different providers, and that it felt like it might be challenging and expensive for them. So that was nerve-wracking. And so they ultimately said they would like an adult clinic, just like the pediatric one, and that would be great, and it would align with their identity. And so we're sitting there thinking, absolutely, that makes perfect sense. They highlighted independence and how, right, becoming a young adult and being independent kind of aligned for them is important. And then they talked about the importance of collaboration, right? Collaborating and choosing what the next step is like. They mentioned, one family mentioned how there was a kind of an abrupt switch. So when I think about transition versus transfer of she was really describing a transfer of care that happened from a pediatrician to primary care, and that was really hard for her. And then that's kind of both of those. So immediate concerns that come up, that if they're not aware, it can be really stressful. So I think what this highlighted and what we kind of took away from this is that they are okay and open to transitioning to adult providers, but they want to be a part of the decision and a part of the conversation. And then in a dream world, they would love for it to feel similarly, that it is a one-stop shop, so that they don't have to take PTO to kind of take their child, their young adult child, to their different appointments. You can advance. So then we took kind of that information from retreat. We put in the plan in our clinic. And if you could populate all the different images, that'd be Great, wonderful. And so we kind of put that into practice, right? Because yes, we want to transition. Yes, we want them to be involved. And one way to involve them and start the conversation in a structured fashion was transition readiness assessment questionnaires. So we have on the left the track, which is not disease specific by any means. The Duchenne one is so much more specific, really helpful and clear. I think for kind of consistency across some other clinics and simplicity's sake, we ended up going this route for those who were cognitively able to self-complete it. Sometimes we'll fill in the information for them, but kind of ask the questions verbally. And I think what's really important here that I want to draw your attention to, but is very, very small, is that at the bottom, it kind of has them rate their importance, kind of how important this is to them, kind of on a Likert scale. And that is a really great opportunity that I hone in on based on whatever they rank there to kind of do a little bit of motivational interviewing and kind of move them towards stages of change to feel interested, able, and kind of empowered to be involved. And then on the right, you have kind of a two-pager for those with developmental intellectual disabilities, where it really isn't appropriate for them to be independent in their care in this kind of way. And so the options here are, yes, my youth knows how to do this, my youth needs to learn to do this, or I need to learn to do this, where they're able to identify things that they just need to be better equipped and ready to do so that someone from the household is able to support this transition. And then you can advance. So then we kind of took a second look at it, right? So we had the qualitative information. We started getting some kind of objective data through the transition readiness assessment questionnaire. And we kind of took a look to see kind of how important are these things to them? Are they feeling like they are, able to engage in their care, things like that. And so we did this through patient start report through the track for youth age 14 and above. And some of the take home points here is that a lot of them, and it was really exciting for me to see and for us to see as the team, that they had some really great strengths in communicating with providers. And I think by the nature of our clinic and me being embedded, I actually often would kind of split them away and get some individual time. And it was quite organic in that sense, and just normal for that to occur as opposed to it being for any specific reason. They were, so they identified some things that they still needed to build on, like out of clinic skills. So things like how to make their appointment, how to refill a prescription, what that kind of looks like, were something that they identified that weren't a strength that they wanted to work on. And so they also rated it really important, but that they had not so much confidence in it. And so I think that kind of highlighted for us that our role should be to support them in learning these skills and feeling more and more confident about transition readiness and their involvement in their own care as they kind of continue to grow up. Next slide.
It might be me. Next slide. I think this is just a brief overview of in terms of how are we handing off our medical care to adult providers, right? And again, there's a lot of variability in the practice. It's important to do this medical summary that kind of talks about who are the new providers, what are their roles, and your diagnosis, what things we have discussed already, if there is any urgent care needs, plan of care, advanced directives have been discussed. Like the listed here. The way that we do it in our center is our transition coordinator comes up with, of course, we share all the clinic notes, recent ones, testing, and things like that. In addition to that, our transition coordinator comes up with this transition, mostly one pager, maybe 2-page summary that kind of goes on to all of the adult providers that they work with. I'm curious to hear what's a practice that you guys have about this medical summary handing off. And anyone else in the audience have any comments, please share them as well.
Christine, I think you'd have more insight here on that because our nurse coordinators manage so many of these pieces. But I can talk on kind of the school and work information that comes up in our sessions. We make sure we have a release as indicated and kind of chat with them. And of course, document whatever is necessary and make sure that they have something they're working towards, something they're looking forward to. And if that's not the case, that we offer options through kind of nonprofits and other community-based organizations.
The places that I found the medical summary were the most helpful because I really feel like our chart notes around this time are really comprehensive. And so we're sharing those, and you know, we don't want to make more work for ourselves by duplicating that. But sometimes on the medical summary, we have contact information for home care agencies, or who provides a formula, or who provides their durable medical assistance. So having that content can be very helpful. And some of the patient populations that are not very common, but that have really benefited from it, we have a few individuals that live in care facilities or in group homes, community-based homes, and for them that has been extremely helpful to not only have emergency instructions, but to have who the contacts are for emergencies that do happen in the community. And then we have for, especially from our pulmonary team, they have done letters outlining, if you come to the emergency room with a respiratory infection, do this first, you know, always stay on the non-invasive ventilation. And then they go through a series of like, do this before doing that, especially for those that have requested not to be intubated, for example. So this is an educational piece with the family as well, making sure that they understand what choices they might have in those circumstances. And then making sure it's whatever their choices are documented. And sometimes that may not be entirely clear, but we can put a guideline together of what things to do first.
Sure. Next slide. I think we kind of talked about this. What are the individual roles in our centers? Next slide. Yeah, palliative care involvement. Again, I'm also curious to hear what's the practice in your centers. We try to involve them as early as we can, depending on their availability. So at least they start talking about their roles in the clinic. You know, in some places I hear since the palliative care term may be a little scary, so they change the names of their division of the team. Our hospital team said, no, we are not changing it. We're going to keep calling us palliative care. So I'm curious to hear your thought. You know, how do you guys approach that?
Yeah, I wouldn't say we're as good about doing it early on and frequent. So it ends up being much more in our cases when there is kind of some right and end of life conversations, if they're being hospitalized a lot more, because our palliative care team is much more active on the inpatient side, or if there has been, I'm thinking of a very specific case where there has been kind of a lack of clarity on, and if they're hoping for more kind of a palliative approach or kind of a really do anything to keep them kind of alive and well approach. So kind of sometimes we brought them on to kind of help elucidate what this might look like and how, and in both we will do things in line with what you hope. And maybe we should start this conversation so we can make sure that we're targeting things in the way that you most like. So they end up, I think, getting brought in harder times here in my hospital. You do a better job.
Ours is a little unique again. For years, the social worker and I were part of the palliative care team. So we actually, you know, met with the palliative care providers and the pain management team, so that our conversations were within that context. And then we also were notified when patients were admitted. And then we've kind of transitioned away from that because, you know, my role and the social worker's role are growing in different ways. So palliative care tends to be consulted if they have like a major surgery or hospitalization, but doesn't necessarily follow them in the outpatient setting. In the outpatient setting, we're more likely to have our psychologist assess coping, adjustment, those different pieces. And then we have several times enlisted palliative care in the community, where they can visit their home and see how things are going actually where they live most of their life, not in the clinic.
I think that's involving them early on has been helpful from that standpoint to Christina, from a community going to their house, have a social work that they could talk to outside of the clinics and have that thing continued on. Again, the other challenge is also availability. Right now, all centers have palliative care. Even if they may have one or two providers available. I think that's that, and prioritizing the clinics and the work is another challenge. Right, next slide. Yeah, this is a great one. I don't know if we're doing this.
We are not measuring success.
Right.
I'm not sure that we know.
There are, as you see here, that there are recommendations, a quality measurement framework that you could use to measure this success. But what is success, right? What are we defining success as in transitioning the care, and how are we measuring it? I can say from my standpoint, medically, I'm happy that if they at least get it, we have the 2 visits. If they happily can, complete those 2 visits, I'm fine. But that doesn't define the success. Yeah.
Yeah, I feel good when we haven't lost them, that they haven't stopped going to healthcare. I feel that's a success. I also feel it's a success when we have, high patient satisfaction. I mean, what the family feels like is really important, because I think if they feel good about where things are going, they're more likely to continue and engage. Where if they're dissatisfied, I think that's one of the risk factors for stopping healthcare, stopping their progress.
Yeah, I feel similarly. I think we take a similar approach here, Christina. But I do, in looking at this paper and thinking through and revisiting all these pieces, though, I do like the idea of having, I would love, and we're going to discuss this, of having something to measure success, because we work so hard and sometimes we might not notice. We have qualitative feedback from patients and families, and that's wonderful. But to be able to have it organized and then to make it iterative. So if you're thinking about this from kind of a quality improvement initiative, maybe the initial kind of goal is to get them into the adult side, to not have them fall through care, but maybe then as we kind of continue iterating and improving, we can be more kind of strict and have set a higher bar for what we're hoping that we're able to offer them. So this is a wonderful paper. I really recommend, if you guys are considering this, to kind of take a look. They have wonderful kind of tables and ideas and visuals.
One other thing we hadn't touched upon is where does the primary care providers come into play this whole healthcare transitioning, right? Any thoughts, comments on that?
Again, I feel like sometimes they're forgotten and we've lost that connection. So I think it's helpful when we enlist them, because they often know the local resources, and as adult care really commences, they may know resources that we don't know about. And working together again as a team and extending your team into the community can really be helpful.
No, I agree. I don't know if it is a state that I practice in Arkansas. Most of our primary care providers tend to be family medicine providers. So they kind of, our patients continue to have them as their primary care providers, and involving them in the transition has been very helpful. They have providers that they work with that they know, and then I think it's easy. Hey, cardiology, you're going to follow them. Your primary care provider knows them.
What a fantastic continuity. That sounds wonderful. I can see. Yeah, I wouldn't say we do the best job of enlisting primary care here either. I feel like our patients will often kind of treat us a little bit like their primary care provider, because they see us so much more often. And so this is a good reminder for me as well.
Yeah, we get a lot of messages, all of us. Hey, can we get some antibiotics prescribed for ear pain? Sure. All right, next slide. I think back to Christina.
So in summary, neuromuscular disorders are complex. They represent a patient population that's at risk for difficulties in transitioning to adult healthcare as well as adult lifestyles. Transition planning occurs across several years and can be more comprehensive when listing a team approach. Anticipatory guidance allows time to plan for changes in healthcare, caregiving, housing, transportation, futures after high school, and social networks. Transition planning should include urgent care planning and palliative care services. And we look forward to any additional comments or questions as we close our part of the presentation. And here is a list of some resources that were listed in addition to those along the slides that we presented, having to do either with transition. Most of them are specific to transition in different populations.